Tonight we're going to talk a little bit about osteoarthritis, specifically of the hip and knee, a little bit about the etiology of it, a little bit about the treatments, and then we'll go a little bit more in depth and talk about joint replacement a little bit. So everybody that comes into my office, for the most part, that last word on the slide, pain of some way, shape, or problem is the number one reason that we see people, obviously in orthopedics. Probably accounts for better than 70% of most medical visits, even to primary care physicians. Unless you're just going in for routine checkups, it's some type of pain. Most commonly back pain, but I don't deal in that, and we're not going to talk about that tonight. So, we'll talk a little bit briefly about the knee. Just for starters, I'll give you a little bit of an overview as far as the knee goes. The knee is the main joint in the lower leg between the femur or thigh bone and the tibia or shin bone. The joint surface is covered by what we refer to as articular cartilage. It's basically a soft, cushiony material that is designed to absorb stress. For those of you who like chicken, if you look at the end of a chicken leg and you see that white shiny substance on the end, that's what that is. It's supposed to be nice and smooth, nice and glassy, not have any divots, pits, ruts, or any abnormalities in it. And it's that way when we're born and when we're kids, and from then on it goes through constant changes as we get older. Unfortunately, it doesn't have any ability to really repair itself very well other than when we're extremely young. And that's why we end up with these problems. The knee has some extra cushions in it called the meniscus, which is a little different type of cartilage that acts like a shock absorber in the knee, only because that's a soft tissue structure in between the bones. That tends to wear out a little bit as we get older too. Outside of the knee, you have the ligaments that hold it together, kind of join bone to bone. The tendons attach muscle to bone. In the knee specifically, there's a little bone within one of the tendons called the patella or the kneecap, as we all know. And that's a big component to knee function also. The main muscle that helps the knee function is the quadriceps in the front, hamstrings in the back. Knee pain isn't always arthritis, obviously. You can have various problems with these ligaments, with the meniscus, with the muscles and the tendons that attach the muscle to bone. So those are frequent common causes of knee pain also. The knee joint is kind of a hinge. Structurally, it's stable from the ligaments and the tendons around it. The hip joint is a little bit different. Basically a deep ball that sits on the top or the other end of the femur from the knee that sits in a socket that's created by the bony structures of the pelvis. So it's a very deep, stable, bony joint. There are muscle attachments around it. There's some ligament attachments around it, but they don't contribute to the stability of the hip as much as they do in the knee joint, mainly because that ball sits pretty deep in the socket. So we touched on cartilage a little bit already. You know, it's kind of this cushiony material, and there's a variety of analogies that you can use. The general one I use for people is that it's kind of like the tread on the tires of your car. It's as good as it's going to get on day one, and then it progressively wears out over time, and that depends on a lot of specific factors that we'll get into in a minute. But it's because it really can't regenerate itself very well, inevitably there's going to be wear and tear over time. In the hip, same type of thing. There's a cartilage cap on the end of the bone, probably about 3 millimeters thick, some areas as little as 2. There's a little bit of a cushion in the socket part of the bone itself, but not a tremendous amount. So what are the symptoms of hip and knee arthritis and or problems to begin with? Obviously, we talked about at the beginning pain. Pain's the number one problem. Pain is the number one reason that people seek treatment. Pain, however, is usually the last symptom of arthritis. The hardest thing to talk to people about in joint replacement surgery is people come in and they're complaining of pain that maybe was around for a week, a month, it just happened, and you do an examination, you get some X-rays, and there's a severely deteriorated joint, And then the next thing you're telling somebody is, well, this is what you got. You've got arthritis. You've either got to live with it or you can have your knee replaced. And you know, if people have had pain for a week or 2 weeks or 3 weeks, they kind of look at you cross-eyed and say, well, no, come on, how can that be? I've never had pain before. I had this minor little injury or something like that. And the problem is pain's usually the end stage. You know, when you get pain, usually, it's not always the case, but a lot of times. And again, it's because that cartilage, it starts to deteriorate the minute we start walking. And over time, that degeneration builds up. How much it builds and how much it wears depends on a variety of factors. But a lot of times, it's asymptomatic. There's no pain for years and years and years. And then one little thing happens, you know, that kind of upsets things. I usually tell people, when you've got arthritis and you've got the degeneration that's there in the joint, you're kind of riding that fine line. And sometimes it doesn't take much to push you off. The problem is, once you get pushed off, a lot of times it's hard to get back up. And that's what leads to what we end up having to do. Other symptoms: swelling, stiffness, obviously activity impairment, lifestyle changes. Sometimes the arthritis can get so severe that it affects, in the knee, it can affect ligament stability and things like that. It can lead to deformities. Once the cartilage wears out, you can start to wear out the bone, which can also lead to deformities. You can get responses in the bone that most people refer to as bone spurs. Those, if they get large enough, can start to cause some impairment and deformities also. Knee pain, again, knee and hip problems. A lot of times it's arthritis. That's what we're talking about today, but there are a variety of other causes. Like I said before, the tendons can get inflamed, the tendon being a structure that attaches muscle to bone. The lining of the joint can get inflamed. In plain old wear and tear arthritis or osteoarthritis, which is the most common cause, that's usually not an issue, but in the other types of arthritis, like rheumatoid arthritis and other inflammatory types of arthritis, sometimes the degeneration in the bone and cartilage isn't all that bad, but the inflammation in the lining tissue of the joint is tremendous. Bursitis, we've probably all heard of it various times. What a bursa is, if people don't know, bursa is kind of a soft tissue fluid film sac that sits in between the bone and some soft tissue structure. That could be the skin, like in the elbow, or outside of the knee in front of the kneecap, or it could be between bone and tendon. It's basically a little protective layer, but with repetitive friction and certain types of irritation, it has the same properties as the lining tissue of joints. So it can produce a lot of excess fluid. It can get thickened and inflamed, just like the lining tissue of the joints are, and that's what causes bursitis. Meniscus tears and other types of cartilage problems. And then this one here, big one all the time, and a lot of times trying to sort out what's causing the main problem and the main source of the pain. Is it my hip, is it my knee, or does it all come from an underlying back problem? So important to try and sort that out. So this right here is important, okay? You can't treat what you don't know. You know, I've seen people go in for hip replacement and they come out and they're no better. Okay? Why? Because it probably wasn't the hip at all that was causing the pain. It was probably a herniated disc or some kind of back problem that was the source of the pain. And you go through a lot of surgery and a lot of risk and no solution. So you got to start out with proper diagnosis. And what do we do by that? Well, we've all been through this routine, asked 50 million questions when you walk in the door of the doctor's office, and everybody gets upset, and all they really want to know is, why does it hurt? Well, there's a reason why we start with all this and why we ask 50 questions, because sometimes it's not readily obvious. And subtle little things in your past history and things like that are real important. Associated symptoms other than the pain are extremely important. And then when it comes to arthritis and what our ultimate decisions are, questions about your overall health have a huge impact on what your treatment options may be. Somebody who's got really bad lung disease or really bad heart disease and may not be the best operative candidate in the world, the last thing you probably want to have is a surgical procedure to solve your problem, which could make, you know, your other problems worse. And desired activity level. What are you used to doing? What are you not doing that you want to be doing? What do you want to be doing that's a little bit unrealistic? All those are important questions when we're trying to solve the problem and come up with a good solution. Obviously, an appropriate physical exam, all these things, are things that we look at, not necessarily a big issue from your standpoint. X-rays, some people, the X-rays are important, and recent X-rays are important. And the reason that recent X-rays are important is because, like I said, the state of joints changes on a regular basis, whether you think anything has happened or changed or not. A lot of people are reluctant to have X-rays on a repetitive basis. I understand that. There's always concern for radiation exposure and things like that. But if you're coming into an orthopedic surgeon's office with concerns about arthritic problems and joint pain and things like that, and you have X-rays that are older than 6 months, he or she is probably going to want to repeat them. The other #1 reason to repeat X-rays, especially in the knee and hip, is the majority of X-rays that are taken at other facilities that were ordered by primary care doctors or other physicians are non-weight-bearing X-rays. Non-weight-bearing X-rays are absolutely useless to me. When you're lying down and not putting any weight on your joints, they might look markedly better than they do when you're standing. You may not have a deformity in your knee when you're laying down because you can straighten it out. When you weight bear and you have no cartilage on the outside of your knee and you have ligaments that are lax, when you stand up, your knee may go like this. Okay? I can usually see that, but it helps to get a picture of it, an X-ray too. Same thing in the hip joints. So that, we don't, I shouldn't say we, I don't take X-rays just to take X-rays. I take X-rays when I need them. But there are reasons why people will ask you to have new X-rays taken, even if you've just had some 3 months ago, 6 months ago, certainly a year ago or more. They're important to see what's happened, but they're not necessarily useful for the immediate problem.